It's really a pleasure to be able to share my prejudices about nutrition with you. Every speaker has their own prejudices, and that's what I'm going to tell you. I've been asked to speak about the so-called the CHANGE program. And the CHANGE program is the Canadian Health Advanced by Nutrition and Graded Exercise. It's something which we are trying to promote, and I'll tell you in a moment as to what it is. Today's agenda, or at least what we are going to discuss, are, first of all, distribution of healthcare expenditures and why is change necessary based upon these distributions. In other words, can we make a difference to the distribution? Then we're going to talk about the two major problems in health which I consider to be important in the healthcare expenditures, namely the metabolic syndrome and sarcopenia in illness. The other issue is obesity more important than the metabolic syndrome or the other way around? Then benefits of diet and exercise based on evidence. And what I'm proposing to do is to show you evidence which is based on controlled clinical trials. Because I think there's a lot of evidence based on all kinds of population genetics and population studies, which often tend to be fallacious. And finally, I'll talk about the components of the CHANGE program. Within 20 minutes, I hope to do that for you. So now the CHANGE program is designed, it's called the Canadian Health Advanced by Diet and Graded Exercise, is designed to empower and promote physicians of primary care units to treat the metabolic syndrome and sarcopenia, which I will show you presently as being the major costs, major drivers of healthcare costs. And then the diet intervention is helped by a team of dietitians and kinesiologists working with the physician as a team, so that all three work together to do this. So far, generally, physicians work separately in different silos from a dietitian and exercise person. So the first question is, why treat or prevent the metabolic syndrome or sarcopenia? Now, if you look at the healthcare expenditures, you will note here that the cardiovascular disease in blue, musculoskeletal disease in brown, diabetes in greenish, and some forms of cancer constitute the diseases that occur because you have the so-called metabolic syndrome. And I'll tell you what that is in a minute. So if you are able to 100% reduce metabolic syndrome, you reduce your $80 billion of healthcare expenditure to almost $40 billion. A big difference. I don't think that's going to ever happen, but certainly even a 30% difference in penetrance would make a big difference. So this is the area which you would save funds from. So the next question is the cause of disease and death in the Western world. There are two major causes, the metabolic syndrome and infirmity. The basis of the metabolic syndrome is really an epigenetic trait. It's a trait which is created by a genetic change or genetic change in expression based upon your environment. And that becomes inheritable, although it's not a change in your DNA. And it goes under the name of insulin resistance, and I'll tell you in a minute why that happens. And the base of infirmity is sarcopenia. As you get older, there's an inevitable change in muscular force and strength, in particular muscular power. And this is what results in scads of aging seniors who require wheelchairs instead of being able to climb stairs on their own. What is insulin resistance? The interesting thing is it's a genetic trait which is actually beneficial. When we originally came on this earth, there was no food security. We had to hunt. And we had to have a system which protected us against famine. And that system is called the metabolic syndrome. In other words, it's called the insulin resistance. By insulin resistance, what happens is that you basically are able to store nutrients at a very advantageous rate. But when there's plentiful food and there's no activity, it results in obesity, hyperglycemia, hyperlipidemia, hypertension, and inflammation. In other words, what used to be protected us at the times of adversity, time when there was no civilization, is now a danger of killing you prematurely. What is the insulin resistance. This is something, if you are an endocrinologist, you'll be up in horror because you'll say this is oversimplification. Essentially, when you take carbohydrate or any nutrient actually, your blood glucose goes up. This results in insulin secretion, which in turn opens the pores in your muscle. The glucose transporter, GLUT, is inserted in the membrane, and therefore blood glucose now gets into the muscle cell, and thereby, under the action of insulin, is converted to glycogen. So you are storing your food in the area where you most need it, namely your muscle, and very little goes into adipose tissue. The insulin-resistant person is exactly the opposite. The blood glucose now can no longer enter the muscle easily, and therefore gets converted under the action of insulin into adipose tissue, which its detrimental results. So there are two things that happen. You have more body fat, and you have less glycogen. And what is the consequence of that? The consequence is increased body fat, but also depleted muscle glycogen. And that's why today we have a number of people coming telling me, I am exhausted, I can't work at the end of the day, and I'm all the time feeling tired. And that is because of the insulin resistance and the lack of glycogen in your muscle. There's a constant sense of fatigue. In addition, the extra glucose that is not converted to glycogen produces increased oxidative stress, which in turn produces inflammation. So that is why you must fight insulin resistance. What about obesity? And the point I'd like to make is that there's a lot of press about obesity. It is in fact not the danger you think it is. The greatest danger still is insulin resistance. Here is a study. There are two studies. One done by Dr. Sharma, which is a much smaller study, in Edmonton, which proposed the clinical stages of obesity. The point he made was that if you're obese but you have none of the features of metabolic syndrome, your risk is not high. But here is a more bigger study, which is done by Ortega et al., and this is a study of about 17,000 patients. This is actually in the European Journal of Heart Journal. I think it should soon come into print, but I've got the electronic copy. But what does it show? What they showed was that if people were obese, that means they had a BMI of 30 or more, and they did not have the metabolic syndrome, look at the middle. That's the mortality of these people studied between 1995 and 2007. So if you set that as 0, if you have obesity and the metabolic syndrome, then your mortality goes up by 60%. So it adds 60%, the blue line on the other side here, up here. If you've got the metabolic syndrome, but what they did was they actually took all these individuals and tested them on a treadmill for fitness. And if you're fit, then your risk of dying is reduced by 40%. But what is most interesting is that if you take the individual who is not obese and compare them to the individual who doesn't have the metabolic syndrome and is obese, there's a reduction overall of mortality in the non-obese person by about 25%. But if it's adjusted for fitness, there's no statistical difference at all. So the point they make here is that once fitness is duly accounted for, the metabolically healthy but obese person has a benign condition. The metabolically abnormal obese person has a 30 to 50% increased mortality. No difference in prognosis observed between metabolically healthy but obese individuals and metabolically healthy normal individuals. The key role of fitness in this association is very important. And this is a 17,000 patient individual study which has been spanned over 1995 to 2007. So the point I'm making here is it is very important to treat or to prevent the metabolic syndrome. Now the next question is, how do you treat metabolic syndrome? Is diet and exercise better than drugs? Suppose you have a slightly high blood sugar. Should you really take a drug or should you do diet and exercise? And here's a randomized clinical trial. Now I'm coming down to randomized trials, published in the New England Journal of Medicine. 3,000 patients, BMI, body mass index, they're either fat or they're obese, randomized to placebo or to metformin, which is what your GP will give you if you have a slightly high blood sugar, or a lifestyle modification program, which is slight weight loss and physical activity. Now note here the cumulative incidence of clinical diabetes. The lifestyle group does the best. There is no statistical difference between actually metformin and the placebo. The only thing that does make a statistical difference is lifestyle. Let's give a second example. 101 patients with angina randomized to angioplasty or an exercise program. Now, this is published, again, randomized trial in Circulation, good as New England Journal of Medicine, marked stenosis, etc. Note here that the event-free survival in the exercise group is better than in the group that had stenting. And yet you spend money on stenting. So you can see here that there's randomized trial data showing that diet and exercise supersedes medication and interventional techniques. Now, what about diet? Here is another randomized trial published again in The Lancet. It's one of the few real randomized trials of diet at all. There's a control trial, which is a control group which had a cholesterol education step 1 diet. So they gave them what they considered to be the best diet for people with heart disease. Everything else was kept the same, but the group on the Mediterranean diet took an excess of fruits, vegetables, and nuts, whole grains and legumes, and then also some soybean oil. 2 years they were followed, and dietary compliance was checked in this group. And you can see here the adjusted risk of sudden death, of non-fatal myocardial infarction, and total cardiac endpoints dropped from somewhere between 40 to 50%. So that this is just about as good as any drug. And you can see here, there's a definite modification in the diet. There's a very specific targeted change that was done. So a targeted change is important in preventing the metabolic syndrome. Now, how do you convert insulin resistant to an insulin sensitive state? Evidence by control trial, there are 2 control trials. One trial is on exercise, aerobic, and which showed that aerobic exercise is 65% of VO2 max. I'm not giving you all the details. This is again in New England Journal of Medicine. This is again a control study. It is a very complex study in which they did muscle biopsies, etc., to look for glycogen. And in that, it became very clear that if you wanted to convert a metabolically resistant patient to a metabolically sensitive patient, you can't do trivial exercise. You've got to do 65% of VO2 max. And the other point was that an ad lib low glycemic index diet was, again, in a control trial of 400 people, was shown to convert a person's response from a metabolic resistant to metabolically sensitive state. Now, the final thing is reversal of sarcopenia. And again, there's evidence by control trial. Fiatroni and others in the New England Journal pointed out that these were individuals whose mean age was 87 years. Okay, so that we're not talking here about spring chickens being exercised. There are people who you would think should not exercise at all. But what happened was they were randomized into many different groups. But the ones randomized to progressive high-intensity training of hip and knee extensors, 30% of wheelchair patients were able to climb unaided up the steps. Now, I happen to be on the safety committee of the NIH for this particular trial. And I can tell you something interesting. It is like biblical. These people threw their sticks away and walked up. And you can see here that they were able to do this not by trivial exercise. They had to do proper weight training. Now, what are the characteristics of the metabolic syndrome? How do you recognize it? It's pretty easy to recognize. A fasting blood glucose of more than 5.6, a blood pressure of 130/85, triglycerides of 1.7, HDL less than 1 in males and 1.3 in females, and an increase in abdominal girth. But abdominal girth is not necessary. Any 3 of these 5 things is associated with a metabolic syndrome. In other words, you don't have to have all 5. And this can be done by a general practitioner very easily in their office. So this is the change program. The family doctor assesses eligibility, has a diet and exercise questionnaire, obtains consent, and in this case we are doing some genetic testing, which I will not go into at the moment. and then assesses the readiness and counsels them, adjusts pharmacotherapy if it's being done, and then involves a registered dietitian and a kinesiologist. And then, based upon their clinical state, a regimen is created between all three people. Some people can exercise in some ways, others cannot exercise in other ways. They may be able to, some people can take diet in particular form. The whole idea is that this ought to be not a cap that fits everybody's head, but individualized to individuals. And then there's a follow-up weekly for 3 months, and then monthly for 9 months. And the family doctor checks every 3 months. The rationale for this particular program is that aerobic exercise greater than 3 days a week at 74% of VO2 max sensitizes insulin, reduces body fat, increases endurance, and reduces tissue damage. The resistive exercise prevents sarcopenia and frailty. High protein and complex carbohydrate diets cause moderate weight loss, reduce body fats, raise HDLs, and reduce triglycerides. So that's basically the rationale. The diet program in this case, incidentally, was created so that it is targeted to the problem that the patient has. Is it mainly hypertension? Is it mainly high blood sugar? Is it high? And it's individualized. Thank you very much for this. Are there any questions? Yes. Well, I didn't go into this. There's a study by Dumil and others which pointed out that if your protein intake is increased from 15% to 25%, that's what's considered to be a high-protein diet. There is an effect on both the risk factors as well as the others. It's in the British Journal of Nutrition. So I can't hear you properly.
Hello. Can you comment on using the waist-hip ratio as a measure for obesity?
Waist-hip ratio? Yes. Well, the thing is well, there are two ways of looking at the waist. One is an absolute waist, and there is evidence that both the hip-waist ratio as well as simply a waist circumference corrected for ethnicity is probably just about as effective in producing risk. In the so-called white male, it's in excess of 90 centimeters. In the female, it's about 85 centimeters. But you can also use the ratios. They are equally valid.
Can you comment on the DNA testing that you noted in the last slide and what's happening with nutrigenomics or that sort of thing?
Sorry, I didn't quite get this.
The DNA testing on
DNA testing. Well, that's a totally different. We are looking at ApoA5 and also at another one which is related to the metabolic syndrome. And we are going to find out whether there's the reason why we're testing ApoA5 is there's considerable evidence that the relative amount of fat to carbohydrate, its effects on HDL varies depending upon your ApoA5. There are some people actually who do well on a higher fat diet.
Thank you for your presentation. It's very informative. I just have a question regarding high protein complex carbohydrate diet. Should we limit any kind of saturated fatty acid in our diet?
You're talking about omega-3 fatty acids?
No, saturated fatty acids.
Saturated fatty acids. Yes. Well, yes, I mean, the point, I think there's no question about it that saturated fatty acids are detrimental and a higher intake of unsaturated fatty acids is better. But here, the general idea really is that by increasing complex carbohydrates, there's a lot of evidence that if you randomize people into simple versus complex carbohydrates and allow them to eat ad lib, they will eat somewhere between 300 to 800 calories less per day, depending upon how many is the total calorie, if they eat complex versus simple carbohydrates. So there's a change in appetite without, you don't have to tell the person to eat less, they just do it. And the same applies to protein. Protein affects appetite. So there are now a number of studies which have shown that a higher protein intake, like 25% of calories, is associated with a reduced intake of calories in total.
Sorry, do you mind? I just have another question. How much this limitation should be considered? How much saturated fatty acid should be limited?
How much saturated fatty acid should you take?
Should be limited, yes.
I think there are standard guidelines for that, and I don't contest those at all. I mean,
Okay, thank you.
In terms of the change program, where is that taking place? Is that at St. Mike's? Or is that eventually going to be implemented in hospitals? So just
we are running this actually as a pilot program between 3 centers at the moment. This is not provincially funded. No, it's not. It's not universally. But the whole idea is to look at it as an efficacy study, and if it is really effectiveness study, and if it is effective, then in terms of ironing out the difficulties in doing it, then we will be try to promote it across the country.
If there are no other questions, thank you very much, Khursheed. It was great.